Your patient comes in and they have numbness and tingling in their first 3.5 digits. What's the diagnosis? Well, 77% of the time, that alone means it's carpal tunnel syndrome. But it means 23% of the time, it's not. Hey, it's Tim from ChiroUp. In today's webinar, we're going to discuss what are the imposters to carpal tunnel syndrome? What are the other things that you and I should be thinking about? If you'd like to learn more about carpal tunnel syndrome, we have its own webinar. Now, I'll review that very briefly today. We're going to fly through some of these slides, but I'll also give you resources to check out any of the videos that we discuss, and you can take a deep dive into those if you'd like to. So let's get rolling. First of all, we know that numbness and tingling could happen at the carpal tunnel, but it could also happen upstream at the pronator teres. Maybe it's a thoracic outlet. Maybe it's a cervical radiculopathy. Let's look at carpal tunnel syndrome first. We know that that's irritation of the median nerve as it travels through that carpal tunnel, and it affects a big chunk of the population, especially middle-aged females. One thing that we've learned is that patients who have coronary artery disease were likely to have had a history of carpal tunnel syndrome because this is largely a vascular compression. This is the nerve not getting its vascular supply. So if the small vessels of the hand and wrist started to plug up, it makes sense that the big vessels are eventually going to plug up. Another testament to that is 1 in 5 of our carpal tunnel syndrome patients have some changes in the skin and nails. Maybe it's dry skin. Maybe it's nail changes with the longitudinal lines or some dipping, some discoloration, some fungus. Those are indications that this could be a vascular issue as well, and carpal tunnel is on the list. What test do we use for carpal tunnel? Well, paresthesia along those first 3.5 digits that wakes you up is 77.4% sensitive for the diagnosis. So it's a pretty good guess. Phelan's sign is also somewhat useful, 52% sensitive, and then Hoffman-Tunnell sign, not very useful. As far as the recipe, these are the recipe cards from ChiroUp. If you're a ChiroUp subscriber, you can dive in and check out any of these tests in detail, but I'd like to review a couple of them that are pertinent. The first one is the first rule of any compressive neuropathy: push on it. Nerves don't like two things. They don't like traction and they don't like compression. So we'll test them with each of those. Manual carpal compression is simply applying pressure over that patient's median nerve at the carpal tunnel and seeing, does this reproduce their symptoms? We can also tap it with a reflex hammer for Tunnell sign, or we can have the patient compress it themselves with Phelan's test. If they hold this for a few seconds and start to reproduce that numbness and tingling, it's a pretty good indication. The other thing that we can do is nerves don't like traction, so let's put some traction on it. Reverse Phelan's test could create a traction ischemia of that nerve. And then possibly most importantly, we want to do a median nerve test. So neurodynamics is determining, is there a problem with the flexibility or the dynamics of the way a nerve glides, stretches, and moves? So the median nerve test is pretty simple. We're going to have that patient either seated or lying down on their back, as it is in this case. We're going to then bend their arm. Hopefully you're going to do this a little quicker than Dr. Steele does it in this video. This is how he works in general, kind of slow, but it's still a good demo. He's going to take the arm into abduction. He's going to extend the patient's wrist, and now he's going to extend their elbow as well. So basically you're just tractioning this entire median nerve, and you can see at this point in time we could also have the patient laterally flex their head away. So as they flex their head back and forth, as you flex their wrist back and forth, we're saying, what's happening to that nerve? Do we reproduce the numbness and tingling? This tells us there's something wrong with the median nerve. So what do we do? Well, even the American Academy of Neurology says, let's try conservative treatment, that this is a much better option than surgery. One thing that you and I will do is our favorite technique for working out the wrist flexor, whatever that is for you. Maybe you do some sort of massage, maybe you're ART certified or a pin and stretch. But whatever you do, these muscles have to be worked. If you'd like to see how we work them, you can dive into ChiroUp for a detailed description of how to work out the wrist flexors, but I bet you have your own recipe. The other thing that we'll want to do is some neurodynamic treatments of releasing that nerve at the wrist. And so here's how that works. Remember, the median nerve is traveling down through the forearm, through the carpal tunnel, supplying these 3.5 digits. So a good release for that is to grasp their thenar and hypothenar eminence and spread them apart. So what Dr. Steele is going to do here is he's going to take them from a little bit of proximation into a spreading. So he's opening that up as he's extending the wrist here in a second and working that. That almost feels good watching that happen. Somebody who has carpal tunnel has limited mobility of the median nerve at the wrist, and they're going to appreciate this. And again, if you want the whole tutorial, you can dive into the Chiro Up video to check that out, but it's pretty straightforward. The other thing that we want to do, especially if we saw that that median neurodynamic test was positive, is to do a median nerve floss. So this is a similar process. I'll talk about neurodynamics in just a second. The neurodynamic stretch for this median nerve, though, looks like this. It looks pretty similar to the test. And the only difference is you're going to be moving one end and then the other end. And again, I'll dive into this deeper later. What Dr. Steele's doing is he's taking the patient's arm back into extension, and we could also have the patient be moving their head from side to side. Let's take a little closer look at this whole process. That we know that the median nerve, when it's irritated, the entire nerve swells and it limits its mobility. It doesn't matter if that nerve is irritated up by the nerve roots or if it's somewhere in the thoracic outlet or down chain, the entire nerve mobility is going to be impaired, and that's a problem. We know that when we employ neurodynamic therapy, like the preview that you just saw, that's going to have a potent impact. There have been a number of studies in the past few years. This one said that it's superior to exercise in improving strength and function. This one said that it reduces swelling, it improves mobility, and reduces neural adhesions while actually improving NCV studies. That's a pretty big deal. We see that this study said that it has improvements in pain, physical function, and NCV studies as well. This one said it has similar outcomes to surgeries. This was a massive study. And this one said that neurodynamic techniques have significant benefits when it comes to NCV, pain, symptom severity, and functional status. So what are the the fundamentals of neurodynamic treatment? Well, nerves are not like pieces of beef jerky. They're more like bungee cords. They need to slide and stretch. And in fact, if we take a look at this video, what we're going to see is that if this blue cord is the median nerve, when the patient starts to extend their hand, the median nerve is going to stretch and move at different points. So we see this patient extending their wrist, and the nerve tensions up at the wrist. We're also going to see that it tensions the whole way up the chain. As we move up the arm, we're going to see tension the whole distribution. So that nerve is a dynamic structure that needs to move at every point. If there's an entrapment like this rubber band at the elbow, then there's going to be a problem. Well, nerve gliding and neurodynamic releases are a matter of moving one end and then the other. Let's take a little closer look at that. But first, let's look at this median nerve. This is the median nerve in the forearm as a patient flexes and extends their wrist passively. What we're seeing is that median nerve has to move, and when it doesn't, there's a problem. That the first thing that happens when we try to stretch a nerve is we take up the slack, like it did in that model with the blue string. The next thing that happens is it slides through its canal, through its pathway, and then it starts to stretch. And a little bit of stretch is okay, but when tension occurs, that's a problem. Remember, nerves don't like tension. Think of it this way. If I had a bungee cord that was 50 feet long and I pulled on it, each portion of that bungee cord is going to move a little bit. But if somebody were standing on that bungee cord, now all of that stretch is going to be between me and the person standing on the bungee cord. Well, that's what an adhesion represents. That if we have something that's binding that nerve down somewhere and it's not able to stretch, there's a problem, because a nerve can accommodate about 15% stretch before there's total ischemia. At 7%, we start to see ischemia. At 15% stretch, there's total arrest of blood flow. So in this case, when there's something impeding that stretch, there's a problem. Here's the statistic. This came out of the Journal of Hand Surgery that said 15.7% stretch means complete arrest of blood flow. Well, the patient's certainly going to notice that, but they're starting to notice it when we get to 7%. So what's the difference between a neurodynamic test and a neurodynamic treatment? Well, it's simple. A neurodynamic test stretches both ends. So I would extend my wrist, and I would also laterally flex my head away while I'm taking my arm back. In that case, I'm stretching both components. And here you see the patient has her head stretched away, so she's stretching the brachial plexus, and she's taking her hand back, and she'll extend her wrist to stretch that entire median nerve. Whereas a treatment means putting slack on one end, so she's slacking the brachial plexus side while she's stretching the carpal tunnel side. And then as she laterally flexes her head to the left and brings her hand toward her face, now she's slacking the median nerve side while tensioning the brachial plexus side. So A neurodynamic test means stretch both ends of the nerve. A neurodynamic treatment generally starts with stretching one end while relaxing the other and then alternating that back and forth. And we'll see a couple of those in a minute, but I wanted to give you a quick refresher of that. We can employ those neurodynamic techniques for our patient at home. So a median nerve floss is something that they can certainly take home with them. That median nerve floss looks like this. We're tensioning one end and slacking the other, and now we're slacking one end while we tension the other. And we have the patient bring that back and forth. What I tell the patient is imagine that someone slapped you in the face and knocked your head to the side, and then you're going to tip your head to listen to who's running away. And then they come back and they slap you in the face and knock your head to the side and then listen to who's running away. That's a good way for the patient to remember which way is my head moving, which way is my hand moving. The other thing that we can have the patient do is a median nerve glide. So a median nerve glide looks like this. Make a fist, flatten it out, flip that up into a stop sign. Once you flip that up into a stop sign, you're going to spread your thumb away. And then you're going to flip that process over and take your other hand and traction your thumb back. So that simple movement has been shown to have a marked improvement in our patients with carpal tunnel syndrome. Giving your patients a condition report with this exercise boosts their clinical outcomes. So this is one thing that we can have the patient do. We can do it in office as well, and it's manual stretching of the carpal tunnel itself. The way that this works is we just have our patient put their hand up against a wall while putting their other hand underneath their thenar eminence. So you're basically creating an additional stretch of that area. And then we have that patient just lean into the wall to stretch out that carpal tunnel, much like what Dr. Steele was doing when he was taking his hands and spreading apart that carpal tunnel. We're having the patient do this manual stretch at home by pressing their hand up against a wall. We'll also certainly have them stretch out their wrist flexors because so many of our patients with carpal tunnel or pronator teres, or really any irritation along that entire course of the median nerve, are going to have tightness in the wrist flexors. This is a stretch that I like to use for the patient, have them straighten their arm, lock their elbow, and then flex their wrist down. Now we can have them contract against their own resistance. She's trying to flex her hand forward right now against the resistance of her left hand, and then she tractions it back. Now tries to flex her hand forward against her resistance and stretch it back. I find that those carpal tunnel stretches, the contract relax stretches for the carpal tunnel and the median nerve, tend to work much better than static stretches. We know that wrist splints can have a benefit, especially if that patient has the irritation in the carpal tunnel itself. It's something that has merit. A couple of clinical pearls as we wrap up the carpal tunnel component is, remember, it's more common in the dominant hand. Not surprising because that's the muscles that are working harder typically. Bilateral carpal tunnel syndrome should make us scratch our head. There's oftentimes some other involvement. We'll talk about what that could be a little bit later. Anytime we have a neuropathy or a tendinopathy, nocturnal symptoms are very common. And this is very common during pregnancy because there's increased fluid, and that means increased fluid within the carpal tunnel for an additional compression. And don't forget, most of the time, as you won't if you've been in practice for more than a day or so, is that our patients with carpal tunnel syndrome often have double crush partners. There's something else that's compressing that nerve up chain as well. So what could that be? Well, carpal tunnel syndrome affects the first 3.5 digits here, that numbness and tingling. Sometimes that's because of irritation in the carpal tunnel. Sometimes there are things going on in the carpal tunnel, like a ganglion cyst or flexor tendinitis. But oftentimes there are things going on up chain, the pronator teres, TOS, cervical radiculopathies, or even systemic issues. Let's look at that first one, pronator teres syndrome. That pronator teres syndrome means irritation of the median nerve here in the forearm itself. Now, it's oftentimes combined with irritation somewhere else as that double crush partner. But pronator teres syndrome means that instead of just having numbness and tingling in your first 3.5 digits, you also have some numbness and tingling in your palm, because the median nerve that travels through the carpal tunnel innervates the first 3.5 digits. The palm is innervated by this palmar branch here that travels outside the carpal tunnel. So if somebody has purely carpal tunnel, they won't have irritation to this palmar branch of the median nerve. But if they do have irritation to the palmar branch of the median nerve, they're going to have numbness in their palm as well, which means it's probably happening up chain, or at least a component of it is happening up chain. And the most likely scenario is pronator teres syndrome. It's the number 2 cause of numbness and tingling in these first 3.5 digits. We have compression of the median nerve by the pronator muscle as it travels through this loop right here. Our best diagnostic test for this would be push on it, same as any neuropathy. Whether it be a thoracic outlet, push on it, or a carpal tunnel to push on it, or in this case a pronator teres to push on it. So using our manual pressure over the top of that, about 4 or 5 finger breaths down from the crease of the elbow, and just apply some ischemic compression. If that patient says, yes, that reproduces my symptoms, now we can be pretty sure there's some pronator teres involvement. So what do we do for that? Well, we're going to work out that pronator teres. Remember, it comes off of the epicondyle and travels down into the forearm to pronate the arm. So that muscle often develops trigger points here where this green arrow is. This is the origin of the muscle at the medial epicondyle, traveling down onto the radius, and when it contracts, it's going to rotate that, it's going to pronate the hand, rotating the forearm, and this trigger point is often the culprit because the median nerve lives right underneath there. So we can apply an ischemic compression, we can do some massage over the top of that, or we can do a pin and stretch where we trap the trigger point and now lengthen the muscle as we rotate our hand over the top of that trigger point, stripping that out. We can also do a contract, relax stretch, having the patient try to pronate their hand against your resistance and then you supinate it. Pronate against your resistance and you supinate it. If you'd like to dive deeper into either of those two techniques, you can go into the clinical skills tab underneath treatments and search pronator, and you'll be able to see that one. The other thing that we want is to make sure the patient is involved as an active participant in their own recovery. So we have them stretch their pronator teres, which is a contract, relax stretch. We'll start in a supinated position and then have that patient grasp their own hand. When they grasp their own hand, they're going to be applying resistance to that hand. And then they're simply going to attempt to pronate their hand against resistance. So she's taking this into as much supination as possible, and now she's going to attempt to pronate her hand against her own resistance and then stretch into more supination. Pronate her hand against her own resistance and stretch into greater supination. So helping to loosen that muscle up a little bit. One of the other things that we'll always think about anytime somebody has some down chain involvement is what could be happening up chain. And it's likely that the median nerve is the recipient of irritation up chain. We see this study that came out in 2018 said, what's the most likely levels for degeneration? And C5-6, remember C5-6 is where the C6 nerve root comes out. That's by far the most common level of cervical degeneration. It's also one of the 2 most common levels of disc herniations. 90% of them are going to occur at C5-6 or C6-7. So the median nerve gets a lot of potential irritation up chain. How do we identify if it is up chain? Well, these tests are the most sensitive and specific for cervical radiculopathy. Sperling's, distraction, upper limb tension test, which is the median nerve tension test basically, and limitation of ipsilateral cervical rotation. If you have all 4 of those positive, it's 90% likely this is coming from the neck. 3 positive means it's still likely, about 2/3 likely coming from the neck. So Sperling's test is some lateral flexion with some axial compression. If that hurts, it's probably not happening just in the carpal tunnel. It's happening at the foramen, and that the nerve root is being irritated or at least sensitized at that area. Cervical distraction means, does it feel better when I pull up on your head? Do you have relief of symptoms when we take away some ischemic compression? And when our patient comes in with this Bacodi sign or the shoulder abduction sign, it tells us that they probably have some cervical involvement. It's very suggestive of either degeneration or disc lesions. It's also not suggestive of thoracic outlet syndrome. We'll talk about that in just a second. Thoracic outlet syndrome means that we have some compression at either in between the scalenes, between the anterior and middle scalene as the nerves come through the channel, underneath the clavicle, between the first rib and the clavicle for a costoclavicular TOS, or underneath the pec minor where the pec minor attaches to the coracoid and compresses the brachial artery and that brachial plexus. So if the thoracic outlet is irritated in any one of those spots, the patient is more likely to have symptoms. Now, one key differentiator here between TOS and median neuropathy this is one differentiator as far as the ages. Typically it's middle age, and it's going to be much more common in women. And I think one of the things that makes it more common as women is that women have this strap that's causing compression of the brachial plexus. And again, nerves don't like compression and they don't like stretch. So if you're applying a strap that has some pressure on it all day long via a bra strap, now we're going to see that there's increased likelihood and 9 times more common in females. Now here's the thing that I was alluding to. The one thing we want to remember is that TOS will typically involve the fibers that constitute the ulnar nerve. So C8T1 in this distribution, in fact, 90% of patients with TOS have an ulnar nerve distribution. So their numbness is in this first 1.5 digits, not in this 3.5 digits. And as you know, being in practice, if you ask a patient, where's your numbness, they say, in my hand. And if you say which fingers, they say all of them. So having them differentiate. Next time it happens, tell me, is it this 3? Is it these 2? Is it the palm side? Is it the back side for a radial tunnel or radial nerve involvement? Or is it truly all 5, which is possible, but then we have a TOS or at least a multi-level involvement of something. One test that we can use for TOS is the brachial compression test. This is simply applying pressure, and 68% of our TOS patients will have this test as being positive. Costoclavicular test is having that patient in an exaggerated military posture. That approximate the clavicle and the first rib, and if there's compression there and we notice a diminution in pulse at their wrist, now we have a positive costoclavicular. We want to identify which one of those 3 sources in the TOS is positive because we want to tailor our treatment. The only thing that you and I have to give our patients is time, and the more efficiently we can do that, the better off we are, the more patients we can see. So we don't want to treat all of the issues. We want to really drill down and say which part of the TOS is involved, which part of the forearm is involved. Is it the pronator? Is it the carpal tunnel? Our patients get the best results and we get them out of pain most quickly. And Wright's test can help identify, is this happening underneath the pec minor? As we take that patient's arm into hyperextension while we're monitoring their pulse, do we see, is there a diminution in pulse? And always comparing side to side. Is this normal for the patient or is this present on the symptomatic side? One differentiator for cervical radiculopathy versus a thoracic outlet syndrome, in addition to does it seem to affect the ulnar nerve distribution or the median nerve distribution, is what happens when you put your arm above your head. Because this is Bacotti's sign. Patient with a cervical radiculopathy will typically like this posture, whereas this is also basically east sign, the elevated abduction, and patients with TOS will typically not like that posture. If you'd like to look a little bit deeper into the other possibilities for numbness and tingling, like cubital tunnel, radial tunnel, pronator tunnel, we have a hand and wrist exam tutorial. It's on YouTube, and we also have it for our subscribers within the clinical skills tab, so you can check that out as to what are all the other potential causes. Plus, you'll get a lot of other differential diagnoses from fracture, the arthropathies, TFCC, and all the things that we come across with pain, numbness, and tingling in our patients' hands and wrists. Now, we don't want to overlook the possibility of a systemic cause of carpal tunnel syndrome. We know that there are things like pregnancy, but also diseases like hypothyroidism and diabetes. So don't forget those symptoms that our patients may present with. If they come in with fatigue or things that sound more systemic, then we certainly want to rule those out because they could be perpetuating or causing that patient's symptoms. One way to do that very simply is in the ChiroUp database, you're able to request information from a patient. So when we have a new patient come in, we always send out the Chief Complaint Survey, which basically collects their OPPQRST for us automatically when they come in. I have a one-sheet page that says, here's their OPPQRST. It cuts my consult time down by about 90%. But we'll also do the health history and the review of systems. That if they have some of those things that we looked at on the last slide, their review of systems pops them up, and it allows me to be alert to those and identify those issues. If you're a ChiroUp subscriber, you're able to do this right now in the request info section, and this is actually on our EHR page, which we're using the new ChiroUp EHR in our clinic right now. This gets sent out automatically to all of our patients, and it shows up on their first visit SOAP note or anytime that I request it. So that's something that's interesting. If you'd like to learn more about the EHR, you can go to chiroup.com and check out the EHR info tab, and you'll be hearing a lot more about that in the weeks and months that follow. So I hope this information has been helpful to you. for identifying carpal tunnel, how to treat carpal tunnel, but more importantly, just being alert to what are the other things that could cause it, remembering that 23% of the time it's not carpal tunnel, that there's something else going on as well. Hopefully you'll be able to apply this on Monday morning. I'm grateful for you listening to our channel, consuming our content, and most importantly, for contributing to that content. If you have advice, information, or clinical pearls that you could add, I'd love to hear them. I'm Tim at Chiro Up. Together, we will make our profession the undeniable best choice for patients and payers alike. Thanks for watching.